think it is started. Uh, Good afternoon, all. Welcome to the DHN Town Hall 2026. Today, we are discussing on policy, compliance, and the future of digital healthcare in India. Today, with me, the panel present is Dr. 𝗏𝗏, former CEO of National Health Authority (NHA), Dr. Shuchin Bajaj, founder and director of Ujala Cygnus Healthcare, Mr. Avinash Pandey, Group Lead of Digital Health and 𝗖𝗵𝗿, and Mr. 𝗖𝗵𝗍𝒃 𝗂𝗏𝗍, CEO of Data Security Council of India. So we'll start the session with small intro, and then we'll switch over to a question and answer sessions. So good afternoon. I am 𝗍𝗶𝗃 𝗏𝗏, heading the IT in the 𝗏𝗏𝗃𝗃 Max Hospital, Mumbai. I am very excited to moderate this session. We are fascinating inflating point in the Indian healthcare. On one hand, we have incredible momentum in digital adoption has skyrocketed. Telemedicine become mainstream, and patients are more engaged with their health data than ever before. On the other hand, we are navigating completely new regulatory landscape framework like DPDP, NABH digital health standards, and ABDM converging at once. These are not just compliance check boxes. These are fundamental shifts that we will define that will define how we deliver the care, protect patient trust, and build sustainable digital health systems over 1.4 billion citizens of India. So today we are going beyond the policy documentation. We are going to talk about this actually, how this, what this actually means on the ground for hospital leaders, IT teams, and clinicians. Most importantly for the patients. I will introduce the panel in a short brief. We have an exceptional panel today for discussing these points. Dr. 𝗏𝗏 Sharma joins us as a former CEO of National Health Authority. Dr. Sharma has been architect behind some of the India's transformative digital initiatives, including 𝗄𝗵 and ABDM itself. He has seen these policies go from concept to a national scale implementation, and he understands both the vision and on-ground realities better than anyone else. Next panelist is Dr. Shuchin Bajaj, who is the founder and director of Ujala Cygnus Healthcare. Dr. Bajaj brings the hospital operator's lens in the conversation. He juggling clinical operations, patient care, simultaneously with the compliance part like a DPDP, NABH accreditation, ABDM integrations. He knows what it make to policy work in practice. Moving to next panelist, we have Mr. Avinash Pandey, Group Lead for Digital Health at NABH. Mr. Avinash is shaping various standards we have discussing today. He is witnessed firsthand how to implement the digital accreditation at the hospitals and what works, what don't works, and where is the gap, where are the gaps are. Moving to next panelist, a well-known person in the cybersecurity and DPDP space, Mr. 𝗍𝗵𝗁 𝗂𝗏𝗍, CEO of Data Security Council of India. Mr. 𝗍𝗏 is a data governance policy expert. With his view, we will be able to discuss all the compliances, integration, interfaces with our systems and all those things. So welcome to all of you, and thank you for joining us today. We will straight away start with the panel discussion. My first question is for everybody. We'll start with Dr. Sharma on first. We'll start with this question that India's healthcare regulatory landscape is evolving rapidly. What has fundamentally changed in last 2-3 years in view of policy intent standpoint? Dr. Sharma.
Well, thank you very much, 𝗍𝗶𝗃, for introducing the subject and asking a very, very important question as to what has been the fundamental shift in the regulatory framework of India's digital health. So, in the last 2-3 years, I would rather like to go, let's say, with a little earlier. What has happened is that the teleconsultation is the only form of digitization or digital introduction of digital in the health space in our country, maybe about 8, 9, 10 years back. And that trend has accelerated during the COVID times, because during the COVID times we had did not have the freedom to move around, and whenever we felt sick, we started consulting our doctors on telephone, and then sometimes on the sort of video calls on WhatsApp or whatever other mediums. And fortunately, because of the very good connectivity in the country and a very cheap data rates, we were able to do these kinds of connectivity systems. And therefore, during the COVID times, of course, COVID was a great tragedy for the whole world. But in one respect, it actually accelerated digitization. So that digital, sort of consultation with the doctors and more application of the teleconsultation evolved during the COVID period. And during that period itself, in September of 2021, the Honorable Prime Minister launched what is called Ayushman Bharat Digital Mission, which essentially created a framework for the digitization of the health space. So it actually went much beyond the teleconsultation. It talked about digitization of health records, consent manager, the drug registry, then of course the hospital facilities registry, then professionals registry. So basically, on the architect of digital public infrastructure, we created a framework for ABDM, which essentially was launched in September of 2021. Since then, it has been around 4.5 years or 4 years, a few months. And we have been, kind of accelerating the adoption. And large number of hospitals have got into the system. And interestingly, at that point in time, we did not have the DPDP Act, Digital Personal Data Protection Act. But the very basic architecture which we created, which is essentially patient being in the center of the whole thing. It's a patient-centric framework, which means the patient controls the data. That is actually a very important part of the Ayushman Bharat Digital Mission. So that is actually now accelerating, and more institutions are adopting that. So I would frame that journey of the last 4 or 5 years, which means that now we have a clear framework of how we want to digitize the health space, and how we want to create an interoperable, scalable, as you rightly said, it is 1.4 billion people's health service delivery. How we can create a framework which can actually attain these kinds of frugality, cost effectiveness, and which can improve the access of the health and the quality of the health, quality of service delivery. These are some of the things which were the objectives of the digital health, which we have been able to put in the last 4 or 5 years. I hope I've been able to, sort of
Yeah,
answer your
that is correct.
question in
Yeah,
a
that is fine.
broad sense. As we go along, we will be dealing with other aspects of
Sure.
the digital health.
Sure. So basically, COVID becomes a blessings in a disguise for a digital health for the India. Uh, Moving to next, Mr. Vinayak, I want to ask you, where do you see the largest disconnect today regarding policy formation, implementation, or adoption? I want a quick answer because in depth we'll discussing towards the uh, end of this session.
Yeah, so I think we are in a way putting this ecosystem together, which try to bring there are if I look at entire healthcare ecosystem, right? So there is a healthcare provider, there are digital health platforms, plus the medical devices. Then we have insurance ecosystem for that matter, and entire government intervention is happening. And in entire this effort, I think technology providers to the healthcare industry. So all of these four, five, six players, they create this India's entire digital service delivery ecosystem, right? So certainly, if I see from cybersecurity perspective, most of these horizontal laws of Government of India applies to health sector, including IT Act and the requirements of certain, for that matter, the breach or incident reporting requirement to some of those privacy specific thing which IT Act talked about. Definitely, it was applicable to health sector, but eventually as this sector is becoming one of the important after what we did in payment industry, so the health sector is definitely one of the significant sector in terms of all the experimentation of digital public infrastructure that we talk about DPI, and all the effort we put together with this entire architectural understanding that we are putting together, and through which we want to really emulate some of the experimentation in health sector. So I think if I had to really briefly talk about one, there was certainly a data. Now DPDP Act do take care of a lot of those kind of gaps in terms of the policy. Definitely the health sector entire ecosystem is very cautious about the consent and taking patients kind of a views and kind of a consent to do any medical services, but data specific thing is DPDP Act and the rule definitely takes care of it. There was certainly a problem with respect to the medical devices and IoMT, but recently there was this CDSQ, which really brought some level of a requirement of cybersecurity and privacy. So that is definitely one important part is taken care of. Another important thing which I believe is if you have to really understand from the perspective of policy, the health data policy of ABDM is definitely one important part. And then some of those organizations which are serving to the global, they're definitely subjected to a lot of global ecosystem. So if I see from the policy perspective, all of these pieces are coming together from cybersecurity, from privacy, from data, from overall health data ecosystem perspective, and overall even medical devices perspective. So probably we believe these are all bringing the convergence in place. Certainly, there are issues with respect to some of the aspects of the cybersecurity, which probably is not getting addressed in IT Act. But eventually, once the Digital India Act, which Government of India is talking about, with that comes in, so that will get addressed in the course of time.
Thank you, Mr. Vinayak. So addressing on cybersecurity point, we'll take this discussion to Dr. Bajaj. Dr. Bajaj, what do you see? Where is the gap actually you are looking in? If it is it at a policy formulation level, implementation, or adoption level?
Yeah, thank you very much, Deepak ji, and warm greetings and namaskar to everyone. See, from the vantage point of someone running 26 hospitals across small towns and underserved regions, I see digital health not as a technology story, but as a trust story. In the last few years, three powerful frameworks, and due to R.S. Sharma sir, DPDP, NABH Digital Health Standards, and ABDM, have quietly, but I think very decisively, shifted Indian healthcare from being paper-based and fragmented to being data-driven and interoperable by design. So what has fundamentally changed in this is policy, I think, is no longer asking hospitals whether they should digitize. It is asking how responsibly and how safely can they do so. So for operators like us, this is not about ticking regulatory boxes. It is about building systems that can protect patient dignity through data privacy, preserve, I think, clinical quality in digital workflows, and enable quantity of care across institutions and geographies. But the gap which you speak about, I think, is not of intent, but of execution. Most hospitals are digitizing faster than they are governing. We have EMRs, but not always data stewardship. We have telemedicine, but not always digital clinical governance. I think the future belongs to hospitals that treat DPDP as a design principle, and then NABH digital standards as a quality architecture, and ABDM not as a government project, but as a business enabler for scale, trust, and patient loyalty. So especially in small towns, I think digital will no longer be a premium feature. It is how we will deliver equity at scale, which is the most important thing. So I think, as just to close it out, what you asked is the largest disconnect today is between implementation and adoption. The policy intent is actually, on the contrary, quite progressive. I think DPDP, APDM, and NABS digital standards are globally comparable in vision. The regulatory clarity is not the gap at all. It is the workflow integration and incentive alignment that I see the gap as at our level.
Yeah, thank you, Mr. Dr. Bajaj. So data stewardship and implementation at the ground is the gap you are saying. Moving to Mr. Avinash, how should a healthcare leader read a regulatory signals? It is as a compliance mandate or as an ecosystem enabler? The question which just now answered by Dr. Bajaj also.
Sure. Thank you, Deepak. I think that's a very pertinent question. Good afternoon, everyone. So healthcare leaders, they should read today's regulatory signals, I think primarily as an ecosystem enabler and not just a compliance mandate, but only if they respond with the right mindset. Now, like what Dr. Shuchin just mentioned, regulations like, DPDP and ABDM, and now with the NABH digital health standards, I think they're setting the rules of trust, quality, and interoperability for a digital healthcare ecosystem that is already inevitable, right? So compliance is the minimum threshold, and I guess the real opportunity lies in using these frameworks to standardize processes, reduce variability, and build the patient trust at scale. So organizations that treat regulation as a checkbox will struggle with cost and friction as well. Whereas, those that treat it as a design guidance for digital workflows, data governance, and clinical accountability will gain, definitely they will gain long-term advantages, better integration, safer care, and readiness for future policy evolution. So the signal, I think, is very clear. Regulation today is not about control. It is about creating a credible, scalable, and trusted digital health ecosystems. And leaders must decide whether they want to merely comply with it or strategically grow within it. So that is my view on this.
Very nicely drafted. I think the takeaway is it should be taken as a design, not as a compliance or mandate for them. Right. Moving to Mr. Vinayak, how should the healthcare organization interpret the Digital Personal Data Protection Act, DPDP, in the context of clinical, operational, and the patient-generated data?
Yeah, so if you look at, right, so we recently did a study and published a report, very comprehensive report with HIMSS, which is a organization of health sector information management systems society, basically, right? So what we looked at is there are 5 areas that we believe there's still gap if I compare this sector with other sector, because we work with other sectors as well, right? One is the infrastructure in health sector is still a little fragmented compared to what we see in other sectors, right? Second challenge is the human in other sectors, the resources working and the people working a little bit more aware. Here we have a very diverse set of the people engaging and interacting with the IT or information system. Data protection, definitely the entire health ecosystems work on data. So well, in medical service provisions perspective, all the procedural requirement you may be taking care of, but data protection requirement requires you to comply with a lot of those procedural obligations for that matter. So there are a lot of things that needs to be looked at from the data protection perspective in the health ecosystem. And then entire legal foundation with respect to how exactly you legitimize the collection and processing of the information. At the same time, make sure that all the obligations that you are satisfying, at the same time when you talk about DPDP Act, you talk about procedural other outcome liability for that matter, how you take care of that, and how you prepare yourself for a continuous possible challenges from security and privacy perspective that could happen to you, right? So in all of these things, what we look at is most of the health ecosystem has, hospitals or entities has, they have data with them. This data is historical data, they have it for long, and they are trying to digitize it. Basically they are collecting data for that matter, they are also receiving data and also sharing the data for that matter. And nowadays, because of the mobile application and many other digital experiments, they are also getting enrichment of data. And also they also generate data in every transaction, every service that you provide, basically, right? And while we do that, we also see every product and service is now getting more data enriched. The medical service is going on mobility and devices. We are going for more open data ecosystem. One is our own internal requirement, but also government ecosystem also looking up for that. So there's a lot of third-party API interfaces which are coming to deliver those medical services, and there is a significant effort to get cloud capabilities on the medical ecosystem. And a lot of those platforms are becoming more significant in a way that you are relying on the SaaS platforms to provide some of the medical services, and AI is coming on top of it, basically, right? So contextualizing data protection requirement to this kind of complex evolutions that we see. One is the challenges I talked about on the evolution of digitization that we see, and also the kind of UPI experimentation, emulation of the UPI kind of experimentation happening here. So contextualizing privacy for the health sector, looking at these finer nuances in terms of implementation. And as I talked about, it's a challenging thing in health sector, basically. So getting health sector prepared for this is very important in terms of data protection specific readiness.
Correct. Right. So moving on to Dr. Sharma, what are the non-negotiable things which healthcare institution must get right immediately after implementation of DPDP and compliance, which is going to be enforced within 12 months from now, 12, 14 months from now?
Well, one of the things which is very clear is that all the enablers to deliver services, the health services digitally, they are already in place. So, for example, let's take an example of a teleconsultation. In a teleconsultation, what you have is basically authenticating the patient, authenticating the fact that the doctor is actually one of the fellows who is a competent, capable, and also an authorized medical practitioner. So, and then of course, paying the doctor signing the prescription and delivering the prescription remotely. These are some of the things which are required in a teleconsultation situation. Now, India fortunately has done digital identity, which can actually authenticate the identity of the patient, identity of the doctors, number one. It has a payment system like UPI, where you can remotely pay money using the QR code, using phone number, using accounts, whatever. And it has the digital signature on demand, which is called e-sign, where the doctor can digitally sign the prescription and deliver to the patient. So essentially, all the components which are required for digital service delivery in the health space are in place. That's one part. Now, secondly, the architecture of the ABDM, whereby data becomes interoperable. Now, interoperability and actually patient-centric data means that you need to have a unique identifier where the patient can fetch his or her own data and make it available to the doctor, or show it to the doctor, share with the doctor with her own consent. Now, that part we have already got Ayushman Bharat Health Account, which means there is a unique identifier, Aadhaar ID of each person. So that's another enabler. Then finally, we also have the federated data architecture, which means the data does not travel. Data remains wherever the hospital generates. But at the same time, the hospital must link the digital identity of the patient, which is the Aadhaar ID, with the data, so that the patient is able to fetch and visualize all the data. So essentially, what is required is that all the hospitals must ensure that they are able to create the Aadhaar ID in case the patient does not have one. B, if he already has Aadhaar ID, then link the health record which the hospital generates with the patient's Aadhaar ID so that the patient is able to visualize or to fetch that record whenever he or she requires to share it with the doctor or a service provider. And thirdly, the fact that the consent artifact is also there, which is the HIECM, which is Health Information Exchange and Consent Manager, which is already built into the ABDM architecture. So I think what is important is to ensure that the hospitals are able to attach the patient's ID with his or her record so that he or she is able to see and share his or her own medical records with the service provider. That's something very, very important. We have already created about 850 million Aadhaar IDs. We have linked 850 million records. We have a large number of hospitals and the service provider, the health service professionals created their own identity. So that architecture is in place. But what is lacking is that the hospitals, the laboratories, the diagnostic labs, etc., they are not really actively linking the patient's record, and which actually affects the patient adversely because he has to again undergo the various kinds of tests, and that actually means expenditure. So our objective of actually delivering ubiquitous, cost-effective, frugal health services, that needs to be accelerated faster, and therefore the hospitals must adopt the digital health architecture as soon as possible. And as Dr. Bajaj rightly said, that this is ultimately incentive aligned for everybody. It is the hospitals also who are going to benefit. Those who are the first movers will basically create their digital workflows and will be able to reduce not only paper, but will also be able to improve their productivity in terms of delivering health services to people. So therefore, it is not something which is against their interest. But many times, we even things are in your interest, you are a little lazy to actually adopt these things. And thereafter, you will find that you have been left behind in this race of digital service delivery.
Then after it will be taken as a compliance and mandate to implement.
Right.
If it is not implemented in the first place.
Absolutely.
Yeah. Thank you, Dr. Sharma. Mr. 𝗏𝗏, I want to ask the question that healthcare sector is not only collecting the data, but it is generating lots of data, which other industry might not be at that scale generating from the customer. So how it is important to keep it safe, and what is the DPDP impact after implementation will be on patient-specific data, patient's personal identified patient data.
Yeah, so and thank you for asking that question. So usually when we talk about privacy, we always talk about collection and processing of data. We usually don't reflect on the data you generate. And every industry, for example, financial industry, generate data out of transaction. But here, every patient health services that you have been providing, or tests that you are carrying, or the devices through which the patient is going. So every of these generates data, and the data that you generate, like diagnostic to the prescriptions to all the procedures that you carry, basically, right? It has a lot of meaning to improve the productivity, efficiency, and possibility out of that data, right? And many times, especially I had looked at some of the digital first health startup ecosystem, for that matter, right? And there is one startup, for example, which has able to create a quite a good scalable kind of offering, and it has reached to a critical mass in terms of the number of patients that it serves. So sometimes that data that you generate has different interests. One of the important interest is definitely public interest, for that matter. If you are in a cancer investigation and you try to find the data of the millions of population, and from that you can also really realize what could go wrong in a particular geography with respect to cancer treatment, for that matter, right? And there is also the competition interest. For example, that data can be leveraged for doing other things. And we know the government ecosystem has been now increasingly talking about API ecosystem, for that matter, right? And a lot of new possibilities can be generated out of the data that you generate out of ecosystem. And third, the important thing is there is a competition interest as well. So portability of data, for that matter, is very important. So this public interest, competition interest, and the innovation interest, for that matter. So all the data that is getting generated, is there a efficient and probably privacy preserving way? And that's what we believe there are ways to share this data while not creating problems for the privacy, basically, right? And a lot of this experimentation, new technology that we see in terms of anonymization, in terms of the differential privacy, in terms of even providing the data in a such a way that you can do all of those possible innovation ideas despite revealing the data in plain text form, basically, right? So how can we make sure that this data centrality that we talk about, and for that matter, in the case of overall economy, we say data is a new oil. So how do we make sure that this oil is extracted and the possibilities are created? But while to do that, you have to assure people on security and privacy. So can you achieve both of these goals together? And there are now quite a good ideas that are coming which can help you achieve both of these goals, basically, right? I mean, in fact, and in security and privacy, in the current context, we don't use any symbol like a lock. We don't want to say that security is a locking thing, basically. So how do we enable a lot of possibilities by adopting some of these new ideas of security and privacy? So there, all the generated data can be leveraged for providing a lot of those possible things, right? And there are a lot of ideas, including security, privacy, and we are talking to Mighty that can we also think about the security and privacy as a public good, and some of the architectural idea, like you can emulate something which happen in the UPR or other kind of a DPI ecosystem for cybersecurity, so that you make things possible without creating problem for security and privacy.
Yeah, thank you. I want to ask Dr. Bajaj, at your point of view, while operating daily operations in the hospital, what do you think are the hospitals in India are over preparing or under preparing for the DPDPA?
Yeah, I think I can give a very crisp answer to it because we are seeing it on a day-to-day basis. I think we are over-engineering for 3-4 things. One is excessive consent forms. The consent forms are increasing both in number as well as in detailing, which is, I think, in the normal routine operational environment of a hospital becomes then another checkbox to tick, because realistically nobody is going to read a very long, complicated 5-page consent form. So I think we are over-engineering compliance in that. Over legalistic privacy notices also, I think we are showcasing to patients as well as clinicians and paraclinical a very, very overly legalized form of a privacy notice under DPDP. And then preparing very complex SOPs that no clinician is also paying much regard to. As a clinician myself, I have seen that the clinical SOPs in relation to the EMRs, OPMRs, IPMRs that our IT team brings to me, it becomes very difficult for me to also understand, let alone send it out to pure clinicians who are doing that. But on the other hand, if you ask me what are we under preparing for, I think the biggest under preparation is in training the frontline staff on data rights. The frontline staff really needs to be aligned on data rights, data privacy, respect, integrity, patient right to the data, who actually owns the data. The training of the frontline staff needs to happen a lot. Second, we really need to embed the consent into clinical workflows so that we don't have to spend extra time or go out of the way to do it. So if during the clinical workflows itself, we can embed all consents, that would be a very important part of preparing for this. We are also, I think, very underprepared on incident response readiness for a breach if it happens, how to take care of it, what to do exactly at that moment, how to make a detailed RC and CAPA for it. Because as per DPDPC, the financial penalties can be quite severe. So how everybody is speaking of that, but then nobody really is speaking of how to make your team ready for a response to a particular incident. We are also, I think, lagging behind in making sure that we minimize the data as much as possible, and also do a differential role-based access to data. So right now what is happening most of the time is everybody has access to a data or no access to data. It is quite a binary kind of a system, 1 or 0. Either you see everything or you don't see anything at all. But how do we make sure that we have a role-based access and you see only what you are required to see and nothing more or less than that? So I think we are focusing a bit too much on documentation and too little on behavior and culture. And as we've learned over the years many times, that culture eats strategy for breakfast. So if you can do all the strategy you want, but if it is not seeped into your culture, in your bloodstream, then it will be very difficult for you to really adopt and live digitization as a process.
Very nicely articulated. Dr. Bajaj, I want to ask you further one question, deeping dive into this. Uh, how it is easier to implement DPDP Act, given the fact that DPDP has a provision to appoint a consent manager or DPO. Uh, do you think a smaller organization which provides healthcare services will able to comply with this? And what about the fines and cost incurred implementing these DPDP in the smaller organization? What is your view?
So I think we have to treat this as another quality framework, and what we have been trying to really proselytize and talk to all the smaller hospitals as part of the NABH initiative. Also, I sit on the NABH board, and my mandate is to take quality digital to the small towns, to the smaller hospitals, where majority of the healthcare is delivered to the Indian communities. Your PIN code should not be determining your destiny for quality healthcare access. So this is what our mandate is, and as a part of this, I think it is our duty to speak to the smaller hospitals and make them understand that investment into these processes, into the security offices, into proper frameworks, into proper digital privacy is not an expense. It is an investment that will yield them multifold returns going forward when they become integrated into the larger system and they stop being a very fringe disintegrated player. So I think that conversation, we've done a lot about quality parameters, NABH accreditation. So when we started out in the small towns, people used to discourage us saying, why do you want to invest in doctor training, nursing training, infection control practices? The community is not going to pay you for this because these are quality things that nobody really puts a financial value to. But when we started doing it, luckily I didn't listen, and we were usually the first NABH accredited hospitals in the towns that we started. And still not very far off also. About even today, when we go to a small town, usually we are the first ones to get NABH accredited, and all our hospitals are NABH digital accredited also. So I think what it has given us is much fewer legal cases, much higher occupancy, much better patient load coming into the hospital, because when you build trust, it carries over into a lot of other things. It is a business decision that really, it is a revenue aggregator for you, the building of trust. And not just on the patient side, on the doctor side also. See, if you are building a small town hospital, it is very difficult to get a cardiac surgeon or a cancer specialist oncologist to come in and practice at those centers, because they don't really trust whether when they're going to operate on a patient, whether the patient will do well or not, or what will be the complications. But when you build all these frameworks and trust parameters into it, the doctors also start trusting you and are happy to work with you. So it allows you to gain patient trust. It allows you to gain the provider trust as a doctor. And then, of course, as a result of this, you can then attract global capital. You can attract partnership with global institutes. In fact, I was at Davos all of last week speaking about this at the World Economic Forum Summit. And sitting on those high tables is only possible when you build quality and trust right into the baking of your business model and not as an afterthought.
Okay. So compliance can be taken for the trust, not as an overburden for any organization. Thank you, Dr. Bajaj. Moving to next session, we'll go to NABH digital standards. So I want to ask Mr. Avinash, how has NABH evolved in response to digital transformation?
Okay. See, NABH's evolution, I think it reflects a very clear recognition that healthcare quality can no longer be evaluated through physical infrastructure, manpower, and clinical protocols. So it must also assess the digital layer that increasingly mediates the care delivery. So if you look at it, traditionally, accreditation is focused on hospitals and as brick and mortar institutions. And over the last few years, NABH has very consciously has expanded this lens to include digital systems as critical clinical enablers. So whether there is electronic clinical documentation, decision support, data integrity, cyber security, or continuity of care across all the digital touchpoints. So the introduction of NABH digital health standards for hospitals and system providers both. For example, for in system providers, we have it for HIS, EMR, and clinic management system at this point in time, and also for disease related digital standards for oncology and diabetes. So having these standards, they mark this shift from digitization as an IT project to digitization as a clinical governance and patient safety issue. So these standards, they embed expectations around data accuracy, auditability, interoperability readiness, and accountability. So, we align very closely with ABDM and are reinforcing the DPDP principles as well. So importantly, NABH is repositioning accreditation from a one-time certification exercise to, I would call it, a continuous quality improvement framework for digital maturity. So the intent is not to slow down the innovation, but to ensure that as digital health scales, it does so in a manner that is, safe, it is standardized and trustworthy for patients, providers, and the ecosystem at large. So this is how NABH has been evolving with response to the digital transformation that's happening all around.
Thank you. Mr. Avinash, want to ask the question, NABH is a not mandatory thing. It is an voluntary thing which hospital can opt. But looking at the success of NABH, do you think why it is successful rather than an compliance or mandatory things which are not going to success? How NABH is succeeding?
See, this is a very interesting question because, while it's not a mandate, right? But what NABH is actually providing is, it's a new program, right? It's been 2 years. And, it's very gratifying that you had around 1,800 hospitals who have registered for the NABH digital health standards, 1,800 already. And what is even more gratifying is that around 70% of them are hospitals which are less than 50 beds. And for far-flung areas, we've had registrations from Manipur, we've had registrations coming in from Jammu and Kashmir. Now, one of the, I would say the reasons why, the hospitals are signing up for the NABH digital health standards is because, we kind of provide a very progressive digital maturity framework. Now, let me give you an example. I'll take an example of HIS on how the digital maturity framework moves from very core basic digitization to a clinical maturity. So in our digital health standards, for example, in stage 1, right, it's foundational digitization, which includes things like patient registration, billing, appointment scheduling, basic ADT, workflows, and digitized labs and radiology reports. Could be PDF or scanned outputs. Now, when you go to stage 2 of our standards of the digital maturity framework, the stage 2 is all about structured clinical documentation. So doctor notes getting captured in a structured formats, nursing notes, vitals, medication orders recorded digitally, electronic order entry for labs, radiology, and pharmacy. And then you move to stage 3. Stage 3 of the maturity is about clinical decision support and interoperability. So there you have alerts for allergies, drug-to-drug interaction, clinical protocols, which are embedded in the EMR, and HL7 or FHIR-based data exchange with external systems. So digital health standards actually allowing hospitals to enter at stage 1 and progressively move towards an advanced EMR maturity without mandating anything from day 1. And I think it is this progressive digital maturity which is kind of attracting hospitals to move on to the adoption bandwagon, because as you are aware, IT skills in smaller hospitals in non-tier 1 cities are very scarce, right? And hospitals find it very difficult to start on journey. They don't, smaller hospitals have come and told us that they don't know where to start, right, on the digital journey. And that is where the progressive roadmap of NABH is really supporting these hospitals start on a digital journey.
Yeah. What do you think? Hospitals approaching accreditation as a checklist or as a quality framework? Yeah, Dr. Bajaj has already answered it quite
So,
very well.
in reality, right, I think we have seen both the approaches coexisting today. But the gap between them is widening. A small majority of hospitals still approach accreditation as a checklist exercise, which focuses on documentation, audits, and short-term compliances. And that approach, right, while it may help achieve certification, but it delivers very limited long-term value. But majority of the organizations who have signed up for digital health standards, they are beginning to use the accreditation as a quality framework, a way to institutionalize, I think, better clinical documentation, data governance, safer digital workflows, and accountability across departments. And for them, NABH standards become a common language between the clinicians, IT teams, and the management. So I think the key shift we are encouraging is that accreditation should not be treated as an endpoint. It should be treated as an operating system for continuous improvement. And hospitals that embed these standards into daily workflows, not just audit cycles, are seeing better consistency, higher clinical confidence in digital tools, and stronger readiness for ABDM and DPDP requirements. So the question is no longer whether hospitals can get accredited, but whether they are willing to use accreditation to actually change how care is delivered in a digital environment. So that is what we are experiencing.
Understood. And what the common gaps you see in the digital documentation, data integrity, and clinical governance?
I think that's a great question. Across hospitals, right, I think the most common gaps are not technological. They are, very foundational governance gaps that surface in these three areas. So first, in if I look at digital documentation, right, we see inconsistencies. Clinical notes are often incomplete, absolutely non-standardized, or entered retrospectively, and that obviously affects continuity of care, medical legal defensibility, and analytics. So the digital systems exist, right, but they're not always embedded into the clinical workflows in a way that supports clinicians rather than burdens them. Now, coming to the second, which is the data integrity, it remains a weak spot. I think there are gaps in master data management, version controls, audit trails, and role based access. So, this becomes critical under DPDP, where accuracy, traceability, and accountability are no longer optional but legally mandated. And third, when it comes to clinical governance, I think digital systems are, frequently seen as IT assets rather than clinical assets. And ownership of data quality, decision support outputs, and alerts is often unclear, right? And that leads to underutilization, or I would say unsafe reliance. So what ties, all these three gaps together is the absence of clear digital accountability frameworks. Now, where clinicians, administrators, and IT teams jointly own how data is created, validated, and used. And addressing this is less about, new software, and it is more about redefining the roles, processes, and leadership oversight in a digitally care environment. So, this is what, we are seeing as common gaps, cutting across the digital documentation, data integrity, and clinical governance. Yeah.
So, data stewardship and taking ownership of the systems is the key takeaway from your point. Thank
Absolutely.
you,
By
Dr.
all
Sharma.
the three, major stakeholders coming together, clinicians, administrators, and the IT teams. Yes, absolutely.
And today it is considered as morely an IT systems rather than other two comes into picture.
Yeah, and
Uh,
people which are in the hospitals, which are actually considering, for example, Dr. Shuchin Bajaj, which are actually considering it as a clinical asset, are the ones who are really leveraging this, the strength of technology. Yes.
yeah. Going to Dr. Sharma, we'll move into ABDM part now. Where does the Ayushman Bharat Digital Mission stands today in terms of adoption versus readiness?
Well, I think the Ayushman Bharat, as I said in the beginning also, the architecture wise, it is actually one of the best architectures which has been created. Let me put it this way, that the United States of America, you have those digital systems are quite in vogue for a long time now. But then what has happened, they're all proprietary. So there are two, sort of firms, two technology firms. One is called Epic and another is Cerner. They actually control about 70 to 80% of patients' data. And those data are not interoperable. So interoperability is at the heart of the Ayushman Bharat digital mission, number one. Number two, it is also the democratization of the data and the patient centricity, which are another aspect of it. The privacy by design is another very, very important, factor in the ABDM architecture. So I think from an architectural standpoint, it is absolutely perfect and quite, sort of appropriate for our country. I, politely disagree with Dr. Bajaj that, this is documentation centric. I think, what has happened is India was the first country which actually created what is called a digital consent artifact way back in 2014. Once the identity of an individual is anchored digitally and anchored in the cloud, then he or she can issue what is called a digital token of consent, which is very granular in the sense that up to what time the token will live, what purpose the token is issued, and all those kinds of things are there. So therefore, the token once hospitals and the institutions understand how this consent artifact works, then the entire compliance with the DPDP Act is not such a great hindrance. And there are now companies which are actually making the consent frameworks. So that also is going to become pretty simple. Ultimately, what is important? The purpose of this ABDM is not really to create a technology architecture. And as spoken by other panelists, technology is only a means to achieve an end. And what is that end? That end is that from the citizens' perspective, they should have better control over their medical records. They should not be able to lose the medical records, leading to repetitive diagnostic tests. And they should be able to discover, access, and avail health services and products, and digital records will save the time. From the healthcare providers, they could make better clinical decisions. Then they could promote the use of teleconsultations. They can have easy and accurate records management. And basically, from the insurance perspective, faster and cost-effective settlement of claims. And lastly, for the policymakers, we can actually analyze public health at national level and state level. Evidence-based policy making can happen. Implement policies effectively at local level. I mean, one example I'll give you of a digital service delivery is 𝗏. We had the problem of vaccinating 1.3 billion people in a very small, window of time, and then in a very accountable manner. And we created what is called a, system which was completely democratic, which was inclusive system, which was interoperable, which was API based, whereby there were a large number of applications at the front end which were able to provide these COVID services to people. And finally, we were able to deliver the verifiable credentials as vaccination certificates to people. And today we have 2.4 billion records in the COVID database. So these are how you design the system. That's one part. The objective is essentially to deliver services to the people. So that is where I think we should focus on, and we should ensure that objective is achieved. And of course, consistent with the DPDP Act, consistent with other things. So that's one part. Adoption, as I said in the beginning, has been quite good to begin with. But then let's remember that we have this architecture and we have these things just recently started, in the sense of 4 or 5 years, and it will take some time. But the sooner the hospitals and service providers realized that this is the right way to go forward, I think that's very, very important. Let us consider that all these stars are aligned. We have a ubiquitous connectivity in this country. We have the digital literacy is also. We have the smartphones, 850 million smartphones. We have common service centers. We have all the institutional things in place which can actually deliver the digital services. And that is what we should leverage. Unfortunately, we have not been able to leverage the facilities and the kind of infrastructure, digital infrastructure, which has been created. And therefore, the sooner we do that, the better it will be.
I think by the mandate of insurance only, we'll see the more adoption in the compliance part of this. What do you think a real barrier to implement this? Is it a technology mindset, incentives, or an execution in the ABDM compliance?
So you see, to my mind, what is happening is somehow this mindset is one of the issues, one of the problems, which I think we need to kind of change. Fortunately, this country is pretty good in adoption of digital technologies. We adopted for example, authentication, payment systems. We have adopted technology. Today, we have got 22 billion payments happening every month on the UPI. We have 150 billion authentications happening on Aadhaar. We have DigiYatra. We have people are getting ration and all that. So using the authentication framework, people are getting mobile SIM using authentication. People are opening bank account using the electronic KYC. So I think people are quite keen to adopt this system, so long as it actually is incentivized in the sense that it reduces their cost, it reduces their harassment, it reduces their kind of life, so to say. It makes their life easy. So people are quite good. Now what is required is service delivery, sort of institutions must also start delivering. And as I said, this is one issue, not of technology, but of mindset in some sense. Secondly, I would go to the extent of saying that now I think the service providers, especially the healthcare professionals, they should also start using digital tools. For example, nowadays you have AI. Now AI is something where voice to text is possible. So basically, a doctor is sitting and then said, okay, paracetamol 500 mg or whatever, twice a day, etc., etc. Once he speaks, that speech gets converted into text, and then they can have the prescription ready, which is a digital prescription ready. So I think again the tools are coming. There are multiple applications I have seen myself. I am myself, in fact, mentoring a group in IIT Kanpur, which actually is producing those digital public goods, which means the doctors can publish their calendar. Doctors can actually prescribe prescription with the help of the all the tools of available on the AI systems. So I think now slowly things are also becoming easy, but it's again a question of adoption. When we started using video conference, for example, today we are very naturally talking to on a video part. But when we started doing it in COVID times, it was very awkward, sitting in front of a screen and then, talking to that screen was sounding very natural. Unnatural. Now it sounds very natural. So essentially, it's a question of how you adopt systems. So I think slowly it will happen, but we need to be conscious and consciously adopting them.
Dr. Bajaj, I want to ask you from your eyes and hospital operator's eyes, what are the barriers you see in the adoption of ABDM?
So, first of all, responding to R.S. Sharma sir's point, I did not mean to say that we are over document centric as a policy. In fact, I said at the policy level, I think we are quite world class and very forward looking. It is just the view of the hospitals themselves. What
Right.
we are experiencing in the small towns, we are over engineering for some things and under engineering for the others, especially as I said, training, etc. And because we are low on training, I think we are overemphasizing on documentation just for safety purposes. But that is more of a implementation side issue rather than a policy issue for sure. I think the frameworks, the guardrails, and the policy itself is very forward looking and very world class. I think the barriers, again, we go back to the same thing. And as I said, the mindset and execution, as R.S. Sharma sir also said. I think the first barrier that we think of reflexly is the technology, whether the small towns and small hospitals are ready for this technology. Are they ready to invest? Is it available to them? Is the internet bandwidth available? I think that is very easily solvable. I think digitally is by far the number one in the world. We travel all across the world, and when we come back to India, we are like so pleasantly surprised that everything that feels very easy to us, like paying by a phone, going anywhere with a phone, doing anything, Digi Yatra, all your tickets are online, all your boarding passes are online, you can pay for everything online. It's not so easily available anywhere else in the world. So the data is practically available for free everywhere. So I think most modern HIS systems that we have in the country can easily integrate with ABDM with very minimal investment. So technology, I think, is very easily solvable. The mindset is quite underestimated. Again, as I said, many small hospitals that we speak to still see ABDM as a government reporting system, rather than a patient engagement and continuity tool which can increase their revenues, which can increase their quality. That is something that we need to disseminate a lot more. Incentives, we really need to align the smaller hospitals on what it is in it for them immediately when they align with ABDM, integrate, when they take up NABH digital standards. In the long term, it is very clear that it will lead to lesser litigation, more patient inflow, better doctor engagement, better trust, ability to raise global funds. But there I think we need to work out some strong commercial or payer driven incentive tied to ABDM participation. And execution, again, most critical, we struggle with, as I mentioned earlier, consent flow design, master data management, staff training, workflow redesigning. So I think ABDM's biggest challenge is not the architecture, again, to clarify. It is change management and change management at scale, particularly in the small towns and the smaller hospitals.
Right. Moving on to next question, I want to ask Dr. Sharma again. Uh, how do ABDM compliance and DPDP obligations intersects? Though the both are very much different, but what is the intersection point of both?
No, first of all, let me sort of agree with Dr. Bajaj. He's very right that it is not a question of non-availability of technology tools that is coming in the way. It's actually the mindset, and that needs to, and we need to do a lot of sort of awareness. Number one, number two, what is also happening is the patient must be benefited, and that patient benefit is central to this entire exercise. Number one, in terms of cost, in terms of time, in terms of other things. So let me give you one example. When we started ABDM, people were saying, what is the use, फायदा क्या है कि भाई patient को क्या मिलेगा? You say longitudinal health record. What longitudinal health record? A poor person is basically putting all these records in his Jola, and he goes there to a doctor, shows a doctor, and comes back, and doctor gives another prescription. He also puts it again back into his Jola, and goes back. And why should patient really think that he will get so many times sick that he will have large number of records available? So that's one of the way. So they said, how can you prove that it is beneficial? So we basically came up with an idea that the hospitals, the public hospitals, there are large lines which are there for getting an OPD slip when they go. And people from Bihar, my state of Bihar, UP, they all come to All India Institute of Medical Science, and then they are falling in line since 4 a.m. in the morning, and then up to 12 when the whole thing becomes they are basically for their OPD cards. So we created what is called a scan and share, which means you go to the hospital like a UPI, there is a QR code, and you scan your ABHA application into the QR code, and you are given a token number. And once you have that token number with you, your data is transferred to the HMIS of the hospital. And then you can go and, once your token details are displayed, token number, you go there and the OPD card is printed. Tomorrow we can even have the OPD card self-printing facility also. So essentially, the patient must start demanding the fact that, my records are kept with you digitally. They are also linked to my ABHA ID so that I am able to get these records as and when I require it. So that's one part. So I think the next stage, one is adoption by the hospitals. Next stage should be the awareness creation in the patient so that patient start demanding. I mean, ultimately, let's put it this way. All the diagnostic tests today are also digital. They may not be machine readable, but they are coming in PDF and all that. If they are actually made linked to the ABHA ID, then it becomes easy for that. So that's one part. Secondly, I think the DPDP Act and the ABDM, while the DPDP Act came later, but we were conscious of the fact that it is consent by design, it's privacy by design. It's only the patient who can actually share, visualize, see his or her own record. If I can summarize the DPDP Act in one single line, it says the person to whom the data pertains is actually the owner of the data, and therefore it is he or she alone who should provide consent for sharing his or her data. That's what DPDP Act, Digital Personal Data Protection Act, which means personal information which is digital should be protected in the as per the direction of the patient. And this is precisely the architecture which is patient centricity of the ABDM. So therefore they are quite congruent. I mean, congruent in the sense that they are quite compliant. So ABDM from day one is compliant with the DPDP Act. Compliance is not an afterthought in the ABDM architecture. That's what I will say.
Thanks for the clarity. I think we have to now move towards the closing part of this session. We are running out of time. So I will quickly ask single questions to everyone, and you are requested to give answer briefly. So we'll close this session in given time. So to Dr. Sharma, looking ahead to 2027, what are the top 3 priorities of healthcare organization should be focused on to move on ABDM readiness to meaningful adaptation? What is the milestone should they aim to hit in next 12 to 24 months?
I think let us be very clear that the digital is the future. And therefore, what we need to do, we need to leverage digital technologies to make the health more cost effective, health service more cost effective, frugal and cost effective, of course. Then, of course, harassment free, patient centric, and quality. These should happen. And this is possible. And that is what hospitals must attempt, not as a checking the text boxes, but essentially to ensure that they are able to improve their productivity and their top line and bottom line. Believe me, it's not something which is going to harm them financially. In fact, the need is huge. You will find hospitals are all overcrowded. Wherever hospitals you open, they are overcrowded. So therefore, the health services are not really very great and adequate in this country at this point in time. And therefore, what we need to expand is to use that. Also, remember that you are able to optimize the use the doctors. For example, there is one project which I am associated with, which I am mentoring. This is called 10-bed ICU project, which basically what it does, it essentially has ICU, model ICU of 10 bed in each district. But because each district does not have specialists, the specialists are sitting at a hub, and therefore they are able to do the tele rounds or virtual rounds of each of these ICUs, and their productivity increases because you don't have those specialists in the rural areas. So I think technology use will make things much better, and that I think is a not 3 but a single priority. You can divide it into various sub priorities, but I think the most important priority should be use technology to deliver better health services, better health care in this country. And I think we fully understand, technology is not going to deliver anything. Technology is only a means, and that means must be utilized to deliver better health services.
Yeah. So technology can be leveraged for better patient outcomes or patient-centric services. Thank you. Moving to Dr. Bajaj, from hospital operator standpoint, you are juggling with DPDP compliance, NABH standards, and ABDM integration simultaneously, all while running the clinical operations. What is your practical 12-24 months playbook? What should be in hospital tackle first? What can we wait for, and how you can sequence these priorities without overwhelming your team or budgets?
I think that's a very good question, and we should really talk to all hospital operators on this. And we need to understand that, as R.S. Sharma sir said, digital is the future, and we cannot escape that. We have to align with it, and we cannot build a skyscraper on weak foundations. So first 6 to 12 months out of the 12 to 24 months you asked, I think the first 6 to 12 months should be totally focused as a hospital operator on building the foundations. So you do the DPDP first principles first, right? Appoint a data protection officer,
Right.
Map all patient data flows, implement role-based access instead of a binary 1-0 access that either you see everything or you don't see anything, and then launch the staff data rights training. Second, I think we need to focus a lot on clinical governance for digital. So we create a digital clinical governance committee, define accountability for EMR quality, and start your periodic digital clinical audits. And then third, as R.S. Sharma sir has already pointed out, that you embed consent by design, right? Embed consent capture in OPD, IPD flows, and then avoid blanket consent. Go to a very specific, purpose-specific consent for each and everything that you do. And then once you've done this, once you build the foundation, then the next 12 to 24 months, I think you can go and scale with confidence. NABH digital standards, we must all use as a differentiator. So use standards to reduce care variability, improve documentation defensibility, and integrate accreditation into daily operations instead of, as sir said, as don't see it as a certificate on the wall. Please do build it into your bloodstream, into each and everything you do, instead of doing it as a once in 2 to 3 years kind of a audit process. And then please do ABDM integration into the use cases with discharge summaries, lab reports, patient access via health IDs, and then train. So training, as I've said, I think 3 times already, is something that's lacking. So train your frontline staff, train your clinicians on digital safety, incentivize good digital documentation, build your KRAs around it, incentives around it, and then build digital leadership at all levels. At your unit level, there should be a digital leadership instead of just the corporate office and the IT director driving all of that. Please build digital leadership at every level. I think these are the first few things that we should prioritize. Unfortunately, most people, when we speak about this, start thinking of analysis of data, how we can use the data to build business cases, build data boards, data lakes. All of that, I think, can wait. But at an operator level, these are the first few things that we should really start building.
Yeah, I think you have given very nice track how to go about it. Thank you, Dr. Bajaj. I will move to Mr. Avinash. The final question: as NABS continues to evolve its digital health standards, what changes or new requirements might you see in NABH in next 2 years? Uh, how should organization prepare for it? And yeah.
Okay. So I think over the next 12 to 24 months, right, around a year or two, I mean, the direction from NABH is very clear. The focus will be on deepening and simplifying the adoption of digital health standards, especially for small and mid-sized hospitals in non-metro and non-tier 1 cities. So the intent is not to raise the entry barriers, but to make digital quality more accessible, structured, and sustainable. So from a standards perspective, right, I think hospitals can expect greater clarity and coverage, including one, I think, expansion beyond the core HIS and EMR systems to other widely used digital applications across clinical, diagnostic, and support services. For example, in the coming 1 year, we'll be coming up with digital health standards for risk packs and also quality management systems. Second is, we already have, disease specific digital health standards for oncology and diabetes, and you'll be seeing, more standards come out, which will be disease specific, and expanding the digital health standards beyond hospitals to clinics. So at the moment, the digital health standards are specifically focusing on hospitals with IP and daycare. Now, we would also be coming up with DHS for clinics. So there will, also be a stronger emphasis on workflow integration, data governance, and outcome-oriented compliance rather than documentation-heavy assessments. So that should, really bring joy to the hospitals, because the focus is going to be on outcome-oriented compliance. Now, equally important is how, NABH is preparing the ecosystem to support this evolution that we are going through. Now, we have deliberately built a very robust digital health enablement framework. So we have a very strong advisory board which provides overall guidance at the strategy level. We have impaneled software testing agencies which actually test the softwares when they go through the assessment process. Very recently, we have put on ground digital mitras. Now, this is a new initiative of NABH, which is to train and impanel individuals and organizations on NABH digital health standards so that they're able to support hospitals in NABH certification and overall digital health adoption. So, right? I mean, we just mentioned, we have been talking about that, especially smaller hospitals and non-metro cities or hospitals there, they, really are not able to attract talent. And this is the gap that we are trying to bridge through the Digital Mitra program. And then apart from that, as a part of the ecosystem, we also have something called Digital Health Promotion Advisory Council, which consists of, CIOs, CTOs, Chief Medical Information Officers, Chief Delivery Digital Officers of leading hospitals in the country. And they play an advisory role, not just to NABH in execution of initiatives, but they play, more importantly, they also play a mentorship role to hospitals and also to the digital mitras, so that hospitals are not navigating this journey alone. And that is what NABH is really focusing on. It is to, equip these hospitals to embark on the digital adoption journey. Now, there are many open source resources, right, that are being provided by NABH. For example, we have theme-based best practices case studies on our website, which have come in from all our accredited and certified hospitals. Then we have something called a digital health toolkit, which provides a very clear roadmap, practical checklist, vendor evaluation guidance, phased implementation, go live support, and a continuous improvement framework. And it ensures that hospitals basically do not have to waste time, effort, or money. Now, this resource is open source, freely downloadable from our website, and it will continue to expand along with skill-based digital health training programs. So we are going to be coming up with skill-based digital health training programs, and we are starting off with, front office, doctors and nurses. So for organizations, which are pursuing accreditation or certification, I think the preparation message is very simple. Start early, focusing on embedding standards into your daily operations, not just audits. Invest in people and governance alongside technology, and actively leverage the NABH digital health ecosystem, which I just talked about. So I think those who approach this as a quality transformation journey and not just a compliance exercise, I think they will be best focused, best positioned for the next phase of digital healthcare in India. So this is what, we as NABH are doing for the adoption of digital health at grassroots level.
Yeah, thank you, Mr. Avinash. You talked about the digital health standards, the future plans, and the resources which you have mentioned is definitely helpful for the audience purpose. Now we are closing this session. Thank you, Dr. Sharma, Dr. Bajaj, Mr. Pandey, and Mr. 𝗲𝗿 for such insightful thoughts and practical insights today. I think it is clear from the conversations that we are not just talking about the compliances. We are talking about building the trust, improving the quality of care, and creating the digital health ecosystem at the patient's point. So I would like to thank everyone in the panel, and it was a learning hour definitely for all. Thank you all the panelists, and thank you Digital Health News also for bringing this live. Signing off for today. Thank you.
Thank you. Thank you very much. Namaskar.
Thank you.
Thank you. Thank you, everyone. Thank you so much.